Thank you so much for hosting me, for giving me the opportunity to participate in this fantastic meeting. And I'm very impressed by the colleagues before myself. I want to present some innovation in the same field. I am a colleague and adjunct professor of neurosurgery here in Milan. My first specialization is skull base. I also I did a lot of spine in the recent years. So what I will share with you will be not only on spine but also on other topics related with the also cranial neurosurgery. So the first consideration, the first comment that I want to share with you is that we are creating so many technologies in any field. Let's say in the operating room, we find a lot of technology and we need to be trained also in the use of the technology. But the point is that any discipline is very different and there are different evolutions. So sometimes we in neurosurgery, we look for new technologies. We want to invent something, but we discover that in neurology probably is already a reality. So there is a different evolution. And in our discipline in particular, in neurosurgery, there is a not sustainable trend. We keep training and keep teaching and learning on patients, and this is not sustainable in any country, I would say, because there is a problem of quality in high-income countries. There is a problem of quantity of surgeons in low and middle-income countries. So there's no covering sometimes. So the problem, I want to start from the problem. We are moving now to an evolution in the way we teach our discipline, and we're moving from a circumstantial to an intentional practice, meaning that now, thanks to the technologies also that my colleagues shared, we can decide when to expose a resident to a specific experience. And this is also thanks to the simulation, of course, and cadavers when are available. The way we learn is very well described in literature. We are not talking about a different way to learn in surgery. It's exactly the same way. We need the repetition. We need, in particular, spaced repetition to learn. And in the same way, we should start thinking and structuring our residency program. If you take 10 residents from the same school at the end of the cycle, they will be completely different one from another because they had different chances, different opportunities, different mentors. And at the end, our training will be randomic. What is happening now with simulation is that we can start mixing cadaveric dissection, experience on cadavers with simulation. So this is the point. Simulation is not going to replace cadavers, is not going to replace patients. Simulation is integrating and preparing and speeding up the learning curve. When we talk about the skill and the spectrum of skill that we need to develop in such discipline like neurosurgery, we are talking about mental and manual skills. I want to say that it's fantastic to see virtual reality, but let me say that if it would be enough, we would be incredible surgeons just watching videos on YouTube, and this is not possible. So we need to practice and we need to do errors. And when we talk about, for example, cranial neurosurgery, as we know, microdissection is a skill that is not a natural skill. We need to develop. It's not something that we have since when we are born, and this is an example on what we need to manage sometimes in vascular neurosurgery. I mean, the emotional impact of training is also very important. What is emotional impact? Is the ability to have the control of any situation like a rupture of an aneurysm. So how could we train to this? We can train a person on a microdissection, but we need to train also on the trauma to have a complication like this. So we say, okay, I did an error, I'll try again. But it's like saying that the pilot, after a crash accident, says, okay, I will try again next time. No, this is not possible. And this is something we need to accept. There is a cultural paradox that we need to fix. The cultural paradox that we have pilots completely validated with simulation, but surgeons are not validated with simulation. Things are changing. In the literature, there is a lot of evidence, but what we need to provide to our residents is not just tools, it's also knowledge, because it's so variable, the kind of information that we give you, that we are creating super technicians with a wrong mindset or a very basic skills. So we need to work on this. Mental training, based on VR, I am a great supporter of mental training, but also manual training for me is absolutely essential. I wanted to remind you that a pilot that is certified with simulation is not using officially a virtual simulator. We have physical simulators because we need to reproduce the same conditions also physically to have the control of any situation and any detail. So the physical point and the physical training is very important. I give you here some example. We use animals, but sometimes this is not ethic or is not sustainable over time. And another thing that I want to share with you, okay, simulation is the principle, but what about the data and the performance? So this is where now the simulation need to go. So if we look at other disciplines, we see how performance data is revolutionizing everything. The problem in our discipline is that there's no objective data, meaning if you look at me, today, you have no idea if I am skilled, if I'm able to practice on a patient. If you are a patient, you have no idea if I'm able to practice on you. We need objective metrics, and this will affect incredibly big environments and big markets, obviously healthcare included. The concept that I want to share with you is this. If we want to compare pilots, we need to have all the pilots on the same field. So the simulation is the only way today to have 100 surgeons on the same complication, on the same patient. And even the same surgeon can be the control of himself after 3 years of training. So the point is, simulation is the common ground where we need to measure abilities. I share with you also my experience with Upsurgeon. I am the founder of this fantastic group of surgeons working with virtual developers to do mental trainings or virtual reality where we can teach at least mentally the steps and then the manual training. So an incredible group of engineers, experts of materials with the goal of not doing just models, but doing operable models, doing operations with complications, with details, and also the possibility to have a mixed reality in the between. Because I may be, could be good for me, for my training, to see with the virtual reality and to touch on something physical. And this is very important. The 5 senses need to be covered by the training. We are doing a strong validation with many leading institutions. This is an example of a vascular simulation where we go through a microsurgical clipping, just to stay on the same topic of the beginning of my talk. But the point is, can we validate the use of these, let's say, toys? Because these are toys until we don't validate it, they are useful to change the performance. And we started having validation with Harvard, for example, an important study where we objectively measured the ability with blinded observers and scorings. And we discovered that after 6 weeks, we had an improvement in the skill. Same thing goes for the let's say, the spine. Here you see a very familiar situation where a master and a trainee are performing an anterior approach to cervical. We say this is an easy approach, but for a resident it's quite challenging at the beginning. At least mentally, you think that there is a carotid to be dissected, identified, and mobilized, and this is not very, it is a bit scary, and obviously we need also a good trainer in this case. And this is where the level of simulation need to go. I mean, we are talking about simulation where we can, for the first time ever, dissect, operate, and even try to feel the carotid pulsation with your finger. And this is the kind of innovation that we want to do, not replacing another simulator, because we don't need other silicone toys today. There are enough in the market. We are trying to replace cadavers. We are trying to prepare to cadavers, even to patients. And for the first time, a simulation with a pulsation is a revolution. So there is a science of materials behind this, and this is what the experience that we can provide today. So the material science is part of this. With the process of 7-step modeling methodology, we started creating a digital and a physical archive of tissue. And now we are scaling up, combining these elements, starting from cranial to spine to ENT, now to plastic and other topics. Once we break down the human being, we can assemble all the components and come and arrive to this. So how, coming back to this slide, how can we do the same revolution at this point on surgery? Now we need to use these fantastic fields to start collecting data. We need to collect this data to start understanding what are the KPI of surgical performance. and how can we try to scale up the understanding of what is the talent and how we can produce technically and reproduce and transfer the talent. How can we do this? Also, obviously, working with a lot of institutions around the globe, and this is the ability that this group has been able to do in the last years. I mean, working with many leading institutions around the globe to start collecting data. But the good thing is that we are not the only one talking about this. There is a lot of literature about the data collection, virtually and physically, and this is very important because it's important to change also the culture. It's not just a group that can change everything. We need the culture, and in this case, I'm sharing with you a few studies where we see sensorizations of instruments, of gloves, of whatever. So collecting data means that we will collect a lot of data, but which kind of data? What of this data is exactly significant in terms of understanding what talent is? This is an example of another prototype where we start from the simulator, a lifelike simulation of a brain surgery, where we start having information on the force that we apply on the brain. So this kind of data is not possible to be detected on a cadaver, not even a patient, and this is the kind of data where we are starting, and this is the next step. Obviously, we are applying now on spine, so sensorizing the hands, sensorizing the instruments and the tissue. We want to understand what happens inside the surgery and understand what is the talent. And this is an ongoing study where we are applying this concept on an initial group of people. So obviously, if we say we identify the limit of force for a brain, it means that we need to compare this with a real brain. This is impossible. What we can do and what we are going to do is to compare a group of experts in doing an aneurysm clipping with a group of non-experts, and we try to understand what are the parameters that change. Another important topic, and I conclude, is the patient-specific. I loved the presentations before me about the patient-specific because you know, training never finished. So when we start being responsible for patients, sometimes happens that we can be in our first experience for a specific case, a malformation. So training to a patient specific is also training. So even a 50 years old super experienced surgeon need training, I mean, prepared to a patient. So imagine a person waiting for the end of a surgery and a surgeon comes and say, your surgery has been successful and you will be operated tomorrow. So imagine to have avatars, and this is actually what we're trying to do, operable, fast, produced avatars, and we are not talking about 3D models. With a big respect of 3D models, we are talking about bleeding, operable tissues. We are talking about bleeding, operable anatomies, and this is actually what we are trying to do with a new technology called 5D printing. This is an example of a brain tumor removal where we compare the residual of a skull-based tumor over the Michael cave and in the simulation and then in the real patient, and there is fantastic correspondence. And we are working on this kind of preview of the surgery. So what I want to say as a final message is, in any discipline in medicine, there is some innovation, and in the other discipline, just behind or just the next door, is not even known. So we need to reinvent the wheel each time. We need to connect the dots. We need to try to create a community where all the disciplines try to share ideas. We are trying to reinvent robotic surgery in neurosurgery, but in neurology, in urology, they use robotics since 20 years. So, I mean, we need to create this kind of interconnection to make the development of surgery faster. Thank you so much.